Hello, this is Dr. Samin Afzal from Hyderabad, Sindh, Pakistan. Sometimes during phacoemulsification or any step of phacoemulsification, some even uneventful things do happen. As in this case, we are operating for a phacoemulsification and grade 2 nuclear sclerotic cataract. A cystotome is passed through the surgical limbus and anterior capsular axis is being performed in the anti-clockwise direction. A round axis of about 5.5 mm has been made. The nucleus is almost grade 2. Cortical cataract. .75 corneal incision is given by a diamond knife in 2 steps, and again our approach is surgical nimbus, and whatever the bleeding is there at the limbus or the incision site, that is a good sign of quick postoperative healing and epithelialization. Side ports in opposite directions are made by 1.4 mm diamond knives at 3 o'clock and 8 o'clock. The advantage of 2 side ports is that they will negate the astigmatism against the rule in old age, also help maintain the intraocular temperature during the release of phaco power during phacoemulsification due to the continuous outflow of fluid from the side ports. And also the side ports are going to help in irrigation and aspiration of the cortical matter at 6 o'clock and 12 o'clock positions. In this case, the phaco settings are phaco power 60, vacuum 550, and flow rate is 40. A vertical trench is created, lens is pushed down, and the equator of the nucleus is exposed, and at the equator of the nucleus the phaco tip is engaged, and by means of a phaco chopper the nucleus is split into 2 parts, and each part will be taken up by applying high vacuum of 550 and continuously chopping, crunching the nucleus into small fragments, as we do usually in chick feed technique. just like a mother hen feeds her chicks, making the small pieces of the nucleus and feeding the small pieces towards the tip of phaco handpiece and taken up or removed out in presence of a high vacuum. Phaco power is not used in this technique. So the chick feed technique has a great advantage that even hard nucleus can be taken up in high vacuum without applying any phaco power, and the corneal endothelium is quite saved. Viscoelastic solution is injected, and now the cortex is removed by two-way irrigation and aspiration Simcoe cannula, an ideal instrument for this purpose. Slowly and gradually we will remove the cortical matter and then again we will inject OVD to make a deep room for the facilitation of intraocular lens. Now we will see that what happens purely an uneventful act during the pushing of intraocular lens into the anterior chamber. And then we have to invert it when the lens is not positioned rightly. Then we have to provide a proper position and a proper direction to the intraocular lens in the bag. This is a hydrophilic foldable intraocular lens. When injected in the anterior chamber to provide a position in the bag, the lens turned upside down and in a reversal fashion. If we keep the same position of the intraocular lens in the bag, patient might develop the error of refraction of myopia, because every intraocular lens has a tilt of 10 to 15 degrees, and now we have to turn it around, invert the lens with the help of a dialer and viscoelastic solution, and then we reposition the lens in the bag after its total eversion. This is most important. If we do not invert it, patient might develop myopic error of refraction. That is also called as a refractive surprise. And now, after eversion of the IOL, the lens is exactly in the bag, facing the haptics slightly anteriorly at the 10 degrees tilt, and the optical portion of the intraocular lens exactly in the bag. According to the biometry, now the image will be formed exactly at the fovea. So these things unexpectedly do happen sometimes in our practice. And whenever we invert the lens in the bag or inside the eye, the bag should be filled with OVD, so that there should be no chances of posterior capsular rupture during the eversion of the IOL. Viscoelastic is now removed, and a cocktail injection of antibiotic, steroid and pilocarpine are given intracamerally behind the iris, because when we give the injection behind the iris, we completely abolish the chances of postoperative endophthalmitis or any sort of postoperative reaction. And whenever the lens is misdirected, we should not get confused and deal with the condition properly. Thank you very much. If you like the video, please subscribe this channel, push the button of